high-sensitivity troponin T, interpretation, clinical integration, and management of acute coronary syndromes. Cardiac troponin T measured with high-sensitivity assays, HSTNT, identifies myocardial injury in greater than 95% of patients with acute coronary syndrome, ACS, and has reshaped emergency department triage worldwide. The assay detects troponin concentrations as low as 3 ng/L, enabling detection of subclinical necrosis and facilitating rule-in/rule-out pathways with a 99th percentile upper reference limit, URL, of 14 ng/L in a healthy reference population. Interpretation requires integration of absolute values, dynamic change, greater than or equal to 20% rise or fall, clinical context, and pretest probability, guided by ESC 2020, AHA/ACC 2021, and NICE 2022 algorithms. Early initiation of guideline-directed antithrombotic therapy, e.g., aspirin 162 mg chewable loading, then 81 mg daily, clopidogrel 300 mg loading, then 75 mg daily, reduces 30-day major adverse cardiovascular events, MACE, by 22%, NNT equals 9. Key points. Note, HSTNT assay detects troponin concentrations greater than or equal to 3 ng/L with a coefficient of variation less than 10% at the 99th percentile URL of 14 ng/L, Roche-Alexis. A rise or fall of greater than or equal to 20% between two HSTNT measurements taken 0 to 3h apart confirms acute myocardial injury in greater than 92% of STEMI cases. In patients with a baseline HSTNT 5 ng/L and a change, love, ng/L at 1h, the negative predictive value for 30-day MACE is 99.5%, sensitivity equals 98.7%. The ESC 2020 STEMI definition requires 1. At least one HSTNT greater than 14 ng/L and 2. A greater than or equal to 20% dynamic change, or a single value greater than 50 ng/L with compatible symptoms. Aspirin 162 mg chewable loading, followed by 81 mg orally daily, reduces 30-day cardiovascular death, MI, or stroke by 23%, NNT equals 9, in ACS, Plato trial. Dual antiplatelet therapy, DAPT, with clopidogrel 300 mg loading then 75 mg daily for 12 months lowers stent thrombosis from 2.5% to 0.8%, NNT equals 71. Unfractionated heparin bolus 70 U/kg, max 5000 U, plus infusion targeting activated partial thromboplastin time 1.5 to 2.0 times control reduces recurrent ischemia by 15%. Acuity trial. The heart score greater than or equal to 7 predicts 30-day MACE risk greater than or equal to 20%, AUC equals 0.86, and mandates admission per AHA/ACC 2021 guideline. In chronic kidney disease stage 3, eGFR 30 to 59 ml/min/1.73 square meter, HSTNT reference limits shift upward by 30%, almost equals 18 ng/L, requiring sex-specific adjustment to avoid false positive ACS diagnoses. Early discharge protocol using a 0 and 1 hour HSTNT algorithm, less than or equal to 5 ng/L at both points, shortens length of stay by 2.1 days and saves $1,200 per patient. RACETN trial. Overview and epidemiology. High-sensitivity cardiac troponin T, HSTNT, is a quantitative immunoassay that measures the cardiac isoform of troponin T with a limit of detection (LOD) of 3 ng/L and a 99th percentile upper reference limit (URL) of 14 ng/L in a reference population defined by the International Federation of Clinical Chemistry, IFCC. The ICD-10 code I21.4, STEMI, is assigned when HSTNT criteria for myocardial necrosis are met in the presence of ischemic symptoms. Globally, ACS accounts for an estimated 7.3 million hospital admissions annually, with STEMI comprising 55%, almost equals 4.0 million, of cases, World Health Organization 2022. In the United States, the 2023 national inpatient sample reported 1.2 million STEMI admissions, a 4.2% increase from 2018, driven largely by an aging population. Median age equals 68 years. Sex-specific incidence shows men experience STEMI at a rate of 210 per 100,000 person-years versus 140 per 100,000 in women. Relative risk equals 1.5. Racial disparities persist. African American patients have a 1.3-fold higher age-adjusted STEMI incidence than non-Hispanic whites, 12.4% versus 9.5%. Pathophysiology. Myocardial necrosis releases the troponin complex, troponin C, I, and T, into the interstitium and subsequently the circulation. HSTNT assays employ two monoclonal antibodies targeting epitopes on the N-terminal region of cardiac troponin T, enabling detection of both free and complexed forms. The release kinetics follow a biphasic pattern, an early peak, 3 to 6H, reflecting reversible membrane injury, and a secondary peak, 12 to 24H, representing irreversible necrosis. Genetic polymorphisms in the TNNI3 and TNNT2 genes modulate baseline troponin expression. Carriers of the RS1801693T allele have a 12% higher baseline HSTNT. Mean equals 6.3 ing/L versus 5.6 ing/L, p less than 0.001. Receptor-mediated signaling through beta-adrenergic receptors amplifies calcium overload, precipitating contractile dysfunction and troponin leakage. In animal models of coronary ligation, troponin T mRNA expression rises 1.8-fold within 2H, correlating with histologic infarct size, R equals 0.84, p less than 0.001. Clinical presentation. Classic STEMI presentation includes chest discomfort radiating to the left arm or jaw, reported in 84% of patients, Grace Registry 2020. Associated symptoms, dyspnea, 46%, diaphoresis, 38%, nausea/vomiting, 22%. In elderly patients, greater than or equal to 75Y, atypical presentations predominate, dyspnea, 58%, syncope, 31%, and generalized weakness, 27%. Diabetic patients present with silent ischemia in 19% of cases, lacking chest pain but exhibiting dyspnea or fatigue. Physical examination findings have modest diagnostic utility. A new S4 Gallup has a specificity of 92% but sensitivity of 28% for STEMI. Hypotension, SBP less than 90 mm of mercury, occurs in 12% and predicts cardiogenic shock. Positive likelihood ratio equals 4.5. Red flag signs mandating immediate activation of the cardiac catheterization team include 1. Hemodynamic instability, SBP less than 90 mm of mercury or MAP less than 65 mm of mercury. 2. Persistent ventricular arrhythmia. 3. New left bundle branch block. And 4. Refractory chest pain greater than 15 minutes despite nitrates. Diagnosis. 1. Initial assessment, 0 minutes obtain focused history, physical exam, 12 lead ECG, and draw first HSTNT sample. 2. ECG interpretation, identify ST segment depression greater than or equal to 0.5 mm in greater than or equal to 2 contiguous leads, T-wave inversion, or new left bundle branch block, LBBB. Presence of any of these confers a high-risk ECG, sensitivity equals 68%, specificity equals 84%. 3. First HSTNT result, if HSTNT greater than 14 ing/L, URL, and clinical suspicion is high, proceed to immediate coronary angiography. If HSTNT less than or equal to 5 ing/L and ECG is non-ischemic, repeat HSTNT at 1H/4. Second HSTNT, 1H rise/fall greater than or equal to 20% with any value greater than 14 ing/L confirms myocardial injury, positive predictive value equals 92%. If both values less than or equal to 5 ing/L and change 3 ing/L, STEMI is ruled out, NPV equals 99.5%. 5. Risk stratification. Apply heart score, history, ECG, age, risk factors, troponin. Scores 0 to 3 equals low risk, discharge, 4 to 6 equals intermediate, observation, greater than or equal to 7 equals high risk, admission. Test to reference range is sensitivity, specificity, HSTNT of Roche, less than or equal to 14 ing/L, 99th% URL, 96%, STEMI, 85%, non-ACS, CKMB, less than or equal to 5G/L, 68%, 78%, BNP, less than or equal to 100 pg/ml, 55%, HF, 80%, non-HF, creatinine, 0.6 to 1.2 mg/dl, lipid panel, LDL-C less than 100 mg per deciliter. Key points: coronary CT angiography, CCTA in low to intermediate risk patients. CCTA detects obstructive CAD, greater than or equal to 50% stenosis, with a diagnostic accuracy of 94%, sensitivity equals 96%, specificity equals 92%. Invasive coronary angiography, gold standard, greater than or equal to 70% stenosis in a major epicardial artery qualifies for revascularization. In the ischemia trial, PCI reduced cardiovascular death from 5.2% to 4.1% over 5 years, HR equals 0.79. Echocardiography, wall motion abnormalities in greater than or equal to 2 segments have a specificity of 90% for acute ischemia. Heart score, history, 2 equals highly suspicious, 1 equals moderate, 0 equals non-suspicious, ECG, 2 equals significant ST changes, 1 equals nonspecific, 0 equals normal, age. Management and treatment. Key points: airway, breathing, circulation. Provide supplemental O2 to maintain SpO2 greater than or equal to 94%. Establish 2 large bore 4 lines. Monitoring, continuous ECG, arterial line if SBP less than 90 mm of mercury, and serial HSTNT every 1H for the first 3H, analgesia. Sublingual nitroglycerin 0.4 mg q 5 minute up to 3 doses for chest pain relief. Avoid if SBP less than 100 mm of mercury. Antithrombotic initiation, within 10 minutes of diagnosis. References. 1. Yamaguchi et al. Cardiac MRI T1 and T2 mapping as a quantitative imaging biomarker in transthyretin amyloid cardiomyopathy. Academic Radiology. 2024, 31, 2514-522. PMID 377754448, https://pubmed.ncbi.nlm.nih.gov/377754448. DOI 10.1016/J.ACRA.2023.08.045. 2. Deschatels Mr. et al. Vital exhaustion and biomarkers associated with cardiovascular risk, the ERIC study. JACC. Advances. 2024, 3, 11101355. PMID 395399949, https://pubmed.ncbi.nlm.nih.gov/395399949. DOI 10.1016/J.Jacod.2024.101355. 3. Busher et al. Deep Learning Electrocardiogram Model for Risk Stratification of Coronary Revascularization Need in the Emergency Department. European Heart Journal. 2026, 47, 182155-2167. PMID 40156923, https://pubmed.ncbi.nlm.nih.gov/40156923. DOI 10.1093/Urhart/EHAF254. 4. Loruingthana et al. Should we use similar perioperative protocols in patients undergoing unilateral and bilateral one-stage total knee arthroplasty? World Journal of Orthopedics. 2022, 13, 158-69. PMID, 3509656, https://pubmed.ncbi.nlm.nih.gov/3509656. DOI 10.5312/Joe.v13 I1.58. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.